Good evening, everyone. Apologies for the delay. We're just having some IT problems with one of our speakers. So you can see myself, I'm Richard Loh. I'm a clinical immunologist at Perth Children's, and Jemma Weidinger, who is our dermatology nurse practitioner. We really hope that in about 20 minutes time, Roland Brand will join us as he's just really having some IT problems. We all work at Perth Children's, and we'd like to share some of the projects and update one for Roland. This is Roland, who's just joined us. Next slide. Great. As I said, we're at Perth Children's. Acknowledgement of country. I'd like to acknowledge the traditional custodians of the land, the Noongar Wanjuk people, and pay my respects to their elders, past, present, and future. In this session, we hope to cover an eczema project that Roland, Jemma, and I have been involved in, discuss a little bit about role, if any, for allergy testing in children with eczema, and Roland and Jemma will update us on treatments that are available now, and we hopefully will leave quite a lot of time for questions. So we all know about eczema, and I'm not going to discuss the various presentations of eczema, but talk a little bit more about a project. Thanks, Jemma. 1 in 4 Australian children will develop eczema. And rather than talk about the physical issues, eczema can have a significant psychosocial impact on the affected child, their family, affect growth and development, school performance, mental health, and general quality of life. There are some recent studies showing a significant increase in suicide rates in patients with chronic eczema. There's a significant cost because many of the treatments, like moisturizers and bath oil and dressings, are not on PBS. So it can cost a family $6,000 a year for a child with moderate to severe eczema. And each year in WA, 6,000 infants will develop eczema. At the start of this project, there was only 0.6 FTE dermatologists and only 3 dermatology clinics. So we had over a 3-year wait before the start of this project 4 years ago. So the wait time reduction within 3 years of this project, funded by the Perth Children's Hospital Foundation, had decreased, and we are maintaining our KPIs to less than 3 months now for non-urgent patients, and urgent patients are seen within weeks. I'm going to discuss very briefly eczema models of care. So part of this funding was for an eczema nurse practitioner, and within 3 years, Roland and Jemma demonstrated the usefulness of this nurse practitioner, and the government, Children's Hospital, are now funding the position. There's also a combined clinic. I know you're from the goldfields, so in this combined clinic, you get to see Jemma for management of eczema. You get to see me. So if there's allergy concerns, I can do skin testing and advice. And usually it's reassured to say there is no allergic component. And the major thing involving GPs is a shared care model. So trying to, like in this webinar, to update you with information available and also to direct you to education resources and other resources to help you in practice. So this is just part of the shared care model. Next slide. GP Connect, you should have received the GP Connect. It's sent out by the WA Primary Health Alliance, and Roland and Jemma really led this article that came out in June. If you have lost it, just Google GP Connect eczema and you'll find it. And the things that I think are really important near the end of the article is the resources. So part of the project funding funded eczema resources for nip allergies in the butt. So you can link on it from the GP Connect. There are resources for older adults, older children and young adults. That's the 250K. We also funded a patient support group in terms of webinars, which are recorded. So again, your patients can get onto these. There are studies, many from WA, saying people from indigenous backgrounds do have significant eczema, and Jemma led a project where there was eczema information for the indigenous families. Resources for GPs in health pathways, there are referral pathways, there is e-training. So we funded e-training, great for CME points if you're running short. I'll talk very briefly about management plan. There's webinars that we've given which are recorded, and you can actually access them. And next slide. Corey Lee, who's a GP, helped us in this, and certainly in a lot of my emails, I know how difficult it is for GPs. There's a lack of new GPs coming in, and also funding of GPs. So in normal funding, if you see a patient 3 times, the normal charge to the family is $46.35 each visit. And what Corey developed is a patient journey, and we developed the GP management plan. We provided action plans. We've got flip charts and videos. Part of it is appropriate, or slightly more appropriate funding for GPs, but it also gives time for the patient and family, for you and your practice nurse to go through resources to help the patient. So this is something that's available, and this is a simple 1-page that we've developed. Next slide, Jemma. It's a managing eczema in child. So when you see a child for the first time with complicated eczema, it's a 1-page. When you are short of time, it talks about what's required, what's mild eczema, management for moderate to severe, and also when to refer and how to refer and to get access. We also have developed a management plan that you can use for your GP management plans. So this is a stepwise management plan, and our patients tell us they like a written management plan. Next slide, thanks. So this is just an example that Corey developed for a pediatric eczema management plan, which is required the GPMP 721. It's a coding, I understand. So it's something that you can help in your practice for patients. So something that's readily available as part of this project. Next slide. The main thing as an allergist point of view is when you see a child with eczema is treat the skin. It is dry skin, and atopic dermatitis is a barrier issue, not usually an allergy issue. Next slide. So dietary triggers of eczema, food allergy coexists in up to 40% of moderate severe eczema patients, but coexist means they have the conditions at the same time, and for most patients, it's not causative. So the patients that warrant skin testing or a specific IG is they have an immediate reaction. You eat it, and you have within an hour hives or angioedema or GI symptoms. There are local irritations that are often not IG mediated, and we see this with tomatoes and strawberries and berries. And then there's a delayed reaction where a patient eats a food and the next day there's exacerbation of eczema. It's not IG mediated, and testing is not warranted. So history is really important to guide us. Next slide. There are sometimes when patients come and say, can grasses aggravate eczema? It's usually not IG mediated. The grasses produce a sap, and often when the kids sit on the grass, they have, if they've got eczema that's not well controlled, they get exacerbation. There's also sometimes dog saliva can exacerbate it as well. Dust mite, the feces of the dust mite, the pH is actually irritating. There was a question in terms of reaction to foods. Yes, we don't like foods in moisturizers. One, it can cause reactions, and 2, it can potentially increase the risk of food allergy, and Jemma will touch more on it. Next slide, thanks. So testing is when there's a good history. I don't test because of for vague reasons, because you get a false positive and you don't know what to do with it. So if you test 100 patients with eczema, 50 will probably get a positive skin test if you test them for 20 allergens. So test if there's a good history rather than test because mom says, could there be an allergy? Blood tests are less reliable, and please never do a food mix. It's got 6 food allergens. If it's positive, we don't know which food is causing it. So test specifically for food. There's no role for IgG testing. There are alternative health practitioners offering it for $600. And the next slide will show you an example of an IgG testing. When it comes back positive, all of us will develop IgG antibodies to foods. And the poor child, when you get this test, is off almost every food. Then there's all the quackery of hair analysis and other things which are rubbish. Okay, parents want a cure, and we don't have it. So my approach is test if there's a good history. All other patients optimize the management of the eczema. And if you can't optimize management with all the appropriate treatments, then I do test to see if there is a small chance the child has got an IgE-mediated reaction. Sometimes if it's non-IgE-mediated, we do food diaries. We eliminate the food and see if there's improvement, but often this is dose dependent. So if it's not IgE-mediated, they can eat small amounts of egg. They just can't eat 2 eggs. And again, as the child gets older, you can titrate it. Okay, next slide, thanks. Roland. Roland's had some IT problems. I'm really glad I saw Roland joining us. So we're just going to go through the lectures and then take questions at the end of it. Thank you. Hi, Roland.
Thank you, Richard. Can everyone hear me?
Perfectly. And see you as well.
And you can hear me?
Yes.
Yes, good. Okay. So I'm going to start with talking about a little bit about the pathogenesis of eczema and then targeted new therapies following on from that. So atopic dermatitis pathogenesis is quite complex and multifactorial. It involves the immune system, the skin barrier, and an interplay with genetic and environmental factors. Next slide. So this is a diagram that shows the basic parts of the pathogenesis. So to the left, you can see the Th2 response is mostly involved in the pathogenesis of atopic eczema with hyperactivity of Th2 and production of interleukin-4, 13 and other cytokines. And this is the so-called inside-out hypothesis pathway of pathogenesis. And then when you go to the right, you can see the outside-in hypothesis where there's a barrier dysfunction of the surface of the skin of the epithelium. And due to the barrier dysfunction, you then get increased irritants and allergens from the surface causing an immune reaction. Now, apart from those 2 factors, you also have the innate itch with atopic eczema, which is one of the diagnostic criteria. And the itch in patients is much more severe than the average population, and there's a hypersensitivity of nerve fibers that then leads to, with various cytokines, to scratching, and then that again in turn breaks the epithelial barrier and causes inflammation. And then the 4th component is the microbiome component, whereby in atopic dermatitis there's an increased pathogenic bacteria like Staph aureus on the surface, which then causes barrier dysfunction and inflammation. So there's an interplay of all 4 factors, and in some patients you may get one factor being more predominant than in others, and these are different phenotypes, and they lead to different endotypes, which I'll go into later. So the next slide. One of the main discoveries in recent years has been the abnormality in Filagrin in atopic dermatitis. So Filagrin is a protein that is produced and that is important in binding keratin filaments and then binding together the keratinocytes, and it forms an anchor. And then as the keratinocytes progress to the surface, to the stratum corneum, the filagrin then breaks down into amino acids, which then forms the natural moisturizing factor, which is important for the moisturizing effect of the surface of the epidermis. So filagrin controls transepidermal water loss. It maintains stratum corneum hydration, and there are numerous mutations in filagrin in patients with atopic eczema, and the more severe mutations are associated with marked increased risk factor for atopic dermatitis and also ichthyosis vulgaris. The abnormalities can also be acquired, and the deficiency results then in increased skin pH and increased activity of serine proteases and production of pro-inflammatory cytokines. So next slide. This slide shows the skin barrier, which can, an analogy of this epidermal skin barrier is a brick wall with a brick and mortar, and the mortar being the corneodesmosomes, which are the protein rivets of the keratinocytes, and these are made up of filagrin. So if you have a deficiency of filagrin, then it produces a leaky brick wall, which then causes surface components to be exposed, the surface of the epithelium to be exposed to irritants and allergens, which then sets up the inflammatory cascade. And also you can see between the epithelial cells, there's the lipid layer, which is also important for the moisturizing effect and the barrier effect of the epidermis. So this is very important in the pathogenesis of eczema. So we'll go to the next slide. So this slide just shows the component of itch being a major factor, and which leads to scratching. You can see the sensory nerve on the left, which responds to the main cytokines of the Th2 cell, like interleukin 4, 13, and interleukin 31. And patients with eczema have a hypersensitivity to exposure to these cytokines with the peripheral nerve, and then that leads to increased itch and scratching, and then as a result of scratching there's a breakdown of the epidermal barrier, then increased Staph aureus colonization, and then this sets off the cascade of inflammation, and it's like a vicious cycle, itch scratch cycle. Next slide. So this slide shows different phenotypes, clinical phenotypes of eczema at the top, and then you can see at the bottom there are different endotypes, which corresponds to what happens with the immune cells and the inflammatory cascade in different populations of eczema. And on the far right, you can see what happens with psoriasis. So generally, you get the Th2 response with acute inflammation and acute eczema, and then when eczema becomes chronic, you get both the Th2 response and often a Th1 response, and the Th1 response is what you normally get with psoriasis. So when you get very chronic eczema like discoid eczema and lichen simplex chronicus, the inflammatory mediator release is very similar and overlaps with psoriasis, and that's why often clinically it can be difficult to distinguish chronic eczema from psoriasis, and it may have similar biopsy findings and also similar inflammatory marker findings, so the treatment there can overlap. And it just goes to show here sometimes with a certain patients like Asian ethnicity and more darker skin African American patients, eczema can look quite different and more difficult to diagnose, which I'll go into in the next few slides. So the next slide, please. So with going through the treatment options, we have some new systemic therapies, which I'll go in, especially talking about Dupixent, Depilamab, and upadacitinib. And these have recently become available on Pbs but the usual algorithm with treatment starts off with topical steroids, then calcineurin inhibitors, which we use, and then I'll talk a bit about phototherapy and also wet dressing treatment and bleach baths. So just going back to the slide, just one back, please, Jemma, if you can. Yeah, so this is the Managing Eczema in Children guideline, which you have all have access to. This is a very good guideline going through like an algorithm of the main steps for general measures for all children with eczema. And then the next part is topical steroids and which topical steroids you can use, which are safe for different areas, for mild eczema, moderate eczema, and severe eczema. And then what to do if they're unresponsive to treatment, and then specialist referral criteria. So with this in mind, the next slide, some of the key points to just mention on that algorithm of treatment is that it's important to ensure that we use the appropriate topical steroids on the skin site that we're treating. And in most cases, like in infants and young children, we start off with methylprednisolone acetonate fatty ointment, which is Advantan fatty ointment. So that's safe to use on the face, the flexural areas, and it can be used in larger quantities long-term quite safely to treat eczema. And if you have more moderate or severe eczema, then you would use mometasone Elicon ointment, or then further beta-methasone dipropionate, which is Alifret or Diprozone ointment for torso and extensor surfaces. The next point is that it's important to apply liberal amounts of topical steroids to cover all the affected areas, not just the worst areas, until the eczema completely clears and the skin feels smooth, and then weaning off the treatment slowly to prevent rebound, and then treating any new areas that reappear immediately to try and aim to keep the skin completely clear. So the aim is not to have any areas remaining of eczema, because that can then cause further flare-ups in distant sites and then result in it becoming chronic. So for most children with acute eczema, you will need at least 1 to 2 weeks of intense use of topical steroids. For chronic eczema, you're going to need at least 4 to 6 weeks. So then the next point is to ensure you use the correct quantity. So there is a fingertip unit measurement guide, which you can use for different sites, and it relates to the number of fingertip use for a certain surface area. But as a rough rule of thumb, I find it's useful to know that if you have, say, a 2-year-old child, to cover the total body surface area with widespread severe eczema, you're going to need 7.5 grams of topical steroid, which is generally half a tube of a standard tube of Advantan, Diprozone, Elicon, or Alifret ointment. And a younger child, say 6 to 8 years of age, you're going to need 15 grams. So that's a whole tube to cover the total body surface area, versus an adult where you're going to need 2 tubes. So if you have, say, a young child, 6 to 8 years of age, who presents with widespread eczema, you're going to need to use at least 2 tubes a day to start treating them, say, with Advantan fatty ointment, using all over the body twice daily under wet dressing. So you'll need to give an authority script for like 10 tubes with 1 or 2 repeats to clear their eczema. So that's the sort of quantity you need to use adequate amounts. Next slide. So this slide is just to show that with different skin types, it can be quite difficult sometimes to judge or assess the amount of eczema and the severity of eczema. And on the left, you can see that normally you expect to see erythematous plaques, whereas in the middle photo with a darker skin type, you will see more darker hyperpigmented plaques. And then on the right, you can see with a darker skin type, hypopigmentation. So hypopigmentation means either that you have a mild eczema, like in pityriasis alba, which is pityriasis alba is post-inflammatory hypopigmentation from mild eczema, or it may be severe post-inflammatory hypopigmentation from treated eczema. And after treating severe eczema, you do get this marked post-inflammatory hypopigmentation, which is often mistaken for a steroid side effect by parents, and that leads to one of the causes of being worried and having so-called steroid phobia because of this hypopigmentation. So we need to reassure parents that this is completely normal and takes time to resolve. And in more darker phototypes, you can see you can't appreciate the severity of eczema. This is quite severe eczema with darker plaques. And again, we need to be aware to use more potent topical steroids to treat this. Next slide. Again, you can see the hyperkeratotic thickened hyperpigmented plaques in darker skin patients, and also some get this follicular eczema where you get extensive follicular keratotic papules that just feel like sandpaper or dry skin, and that's actually eczema, but it's centered around the follicles. It's again quite characteristic in darker pigmented patients, and this is important to know to treat it more aggressively. So with wet dressing treatment, these are the steps to go through, but basically wet dressings is used to help the absorption of the topical steroid, and if topical steroid alone is not effective enough, then you can do wet dressings, which works remarkably well. So the method is basically putting topical steroid on wherever this eczema is, and then applying a damp compress for 15 minutes in usually their clothing or towels, and then after removing after 15 minutes, putting moisturizer on. So you use something like Advantage fatty ointment, 15 minutes of damp compress, and then putting Dermis moisturizer on. And next slide, you can see that the response is very amazing. From the left to the right, you can see the eczema is completely cleared 2 weeks after treatment. And then the important thing then is to wean it off slowly and to watch for any rebound and treat any new areas. And sometimes you need to have a maintenance regime if it's in severe eczema to keep it all clear and keep it under control. So next slide. Bleach baths can be helpful in patients that tend to colonize more Staph aureus, the so-called microbiome hypothesis, where there's recurrent infections, skin infections, and this can reduce the infections and also reduce the flare-ups. And the bleach bath formula is here, which you can look at, and it's a 1/4 cup of unscented white king bleach added to the standard size bathtub, half full, with lukewarm water. And it's quite safe to do twice a week for a few months to reduce recurrent infection. The other thing with recurrent infected eczema would be to decolonize staph, which is a regime over 10 days using Bactroban ointment, nasal, chlorhexidine wash, and antibiotics pending sensitivities on swabs. That's an alternative thing that we may need to do sometimes with recurrent infected eczema. So next slide. So with children over the age of 5 or 6 that have chronic eczema, phototherapy is an older method, and which is now still very useful to break the cycle. And you can see on the left, there's a hand and foot machine, and in the middle on the right-hand side, pictures of a total body machine. So we can treat either hands, feet, or total body. Next slide. And with phototherapy, we use narrow band, which is a band at 311 nanometers in the UVB spectrum, which is 280 to 320. And it has the reason this is used, it has a peak action spectrum in reducing inflammatory mediators of the skin. Initially was discovered for psoriasis, later found to be very effective in most inflammatory skin disorders, including atopic eczema. And a child can usually do this from 5 years or above, depending on compliance, and involves doing 3 treatments per week for at least 12 weeks. And the eczema SCORAD reduction is at least 80% on average after approximately 23 or so treatments, which is approximately 8 to 12 weeks, and it's very safe. There are no significant long-term risks such as skin malignancies, and long-term studies have shown no increased risk of skin malignancy with long-term phototherapy. The mechanism of action, it's found that the photons of 311 nanometers induce changes to DNA molecular structures causing apoptosis of both epidermal keratinocytes and T cells, so it targets both the barrier side of the pathogenesis of eczema and the T cell response. And it suppresses not only the Th2 response, which is the interleukin 4/13 pathway, but it also has marked suppression of the Th1 response, which is the inflammatory pathway for psoriasis. So if you get patients which have a combination of Th2 and Th1, like the severe discoid eczema and lichen simplex chronicus, it's very effective as well. And it reverses all the abnormal changes, the epidermal hyperplasia and aberrant terminal differentiation, and reduces all the immune cells and cytokines after treatment. Next slide. So with systemic agents, up until recently, we were using a lot of azathioprine and methotrexate for severe eczema that have gone through all the steps mentioned so far, the wet dressing treatment, treating recurrent infections, and they've had maximal topical therapies, adequate topical steroids, and they've maybe had phototherapy. So the next step would be to use one of these systemic agents. So we have and still do quite often use azathioprine and methotrexate, rarely now use cyclosporin, but has been in the past. But the 2 newest agents, which are very important, are Depilamab and upadacitinib. And we have quite a bit of experience now already with Depilamab, which is a very effective medication with very low side effects. So Depilamab is an IgG4 monoclonal antibody which binds the interleukin 4 receptor alpha unit, and it inhibits the signaling of interleukin 4 receptor induced by both interleukin 4 and interleukin 13. So this is the Th2 pathogenesis of eczema. So it targets that specifically. Next slide. It is an injection, and it's injected every 2 weeks. And to be eligible for it, there are certain criteria. So we have certain scores for eczema. The ones we use are DLQI, the EASY score, and the PGA score, which I'll briefly go through, but you need to have an EASY score of at least 20 and a PGA of 4 to qualify it. And the patient needs to have been chronic, had eczema for 6 months at least, and has failed medium to high potency topical steroids or topical calcineurin inhibitors. And these have to all be documented. And then the DLQI baseline needs to be documented. So next slide just shows the DLQI, which is a dermatology life quality index with eczema, and a similar one in children. And it has a score from 0 to 30, and it's a questionnaire, and it goes through all the questions about the effects of eczema on a patient. And usually with chronic severe eczema, it tends to be quite high, close to 30. And the next slide shows the EASY score. The EASY score is a bit more complicated, but it's a score similar to the PASI score with psoriasis. An EASY score is 0 to 72, and it assesses the severity of eczema. So basically, it's calculated by the body surface area, and then it's multiplied by 4 different indicators of eczema, and then you get a score. And if over 20, it's considered to be severe, and then qualifies for Depilamab and also for upadacitinib, which I'll talk about next. So the next slide. The PGA is quite a simple score. It's a physician global assessment, and basically it's from 0 to 4, 0 being none, and 4 being severe eczema, and it needs to be basically severe, which is a number of 4 to be eligible. So the next slide. Dupixent, so then in summary, it's indicated for moderate to severe atopic eczema, and it's intended for long-term use, not episodic use, and it is PBS funded for age 12 years and above, and TGA approved for age 6 years and above, and we can get compassionate supply from the hospital, from Sanofi, and also through a special approval through the Children's Hospital in younger age groups, and we have used it at much younger ages, especially between 6 and 11 years of age recently. And hopefully the PBS approval will happen soon for 6 and above. And the dosage depends on the body weight, but generally it's injected every 2 weeks, except for under 30 kilogram body weight, where you have an injection every 4 weeks, and the loading dose is double the maintenance injecting dose. Next slide. So it can only be prescribed by a dermatologist or clinical immunologist, and the Pbs criteria, again, just going through very briefly, the PGA score is 4, easy score at least 20, and it has to be 30 for age 6 to 12 to get special consideration. You can also get it for treatment of bad facial or hand dermatitis, and in fact, if you have a surface area of at least 30% of involvement, or you have the easy subscores being severe, 2 out of 4, then you then are eligible for it. With ongoing treatment for Depilamab, this is assessed at 16 weeks. You have to have a reduction in the easy score of at least 50% for total body involvement, and the DLQI needs to go down by 4 points from the original baseline, and this is quite easily happens, and usually you get in almost every case I've seen so far, you get a fantastic response with Depilamab. With face and hands, you have to have a reduction of 75% of body surface area involvement, and an easy subscore of at least 3 out of 4 being mild or none after 16 weeks of treatment, and a reduction of DLQI as well of at least 4, which is quite easy to get. And so the next slide just shows some of the results and adverse effects. Most patients do respond. If they're poor responders, then most likely have either the wrong diagnosis or there's some other factors that are causing the eczema to flare up, like severe contact dermatitis that was unrecognized. The adverse effects listed here from studies, probably the most important one out of that list is conjunctivitis. That for some reason we don't understand, there is a very high risk of conjunctivitis and blepharitis, around 10% in patients going on Dupixent. And in order to avoid this, we need to use lubricating eye drops and moisturizing the eyelids. And this tends to prevent this complication. Injection site reactions are probably quite rare if it's done well supervised. There are some cases of HSV infection that occur during treatment, and facial erythema can occur, and it's not quite well understood either, the reason for this, but it's generally not a problem. Next slide. So this is an interesting study, pooled analysis from 3 clinical trials of Depilamab in adolescents aged 12 to 17 years of age, over 600 patients, 205 placebo, 407 Depilamab patients, and it was found that the total skin infections was less frequent in all Depilamab treated groups versus placebo. So generally we find with Depilamab the infection rates go down with eczema, so it's a biologic. We don't expect to see infections versus some of the biologics for psoriasis that increase the risk of infections whilst you're on treatment. And the good thing with Depilamab is that you generally don't require any monitoring apart from strong eloides serology, which is recommended to be done before starting it. But the general blood test monitoring is not required as it is with other biologics that we use for psoriasis. This is just a rare complication of Depilamab, showing a psoriasiform dermatitis during Depilamab treatment, and which is interesting because it inhibits the Th2 response, and rarely what you can see is a shift towards a Th1 response, and you may get some psoriasiform dermatitis flaring up, and this is usually settles with topical steroid use. So next slide. So the next medication that's recently also been listed on PBS and is available with the same under the same protocol is Upadacitinib, which is Rinvoq, which is a completely different medication. It's a second-generation Janus kinase inhibitor, and it's selective for Janus kinase 1, and which is one of the 4 JAK receptors. And it blocks the cytoplasmic tyrosine kinase, whose function is to transduce cytokine-mediated signals into the nucleus through the JAK-STAT pathway. So what it does is it inhibits the transcription of numerous inflammatory cytokines in the nucleus by inhibiting their passage from the cytoplasm to the nucleus. So it has more of a general effect on cytokines, and it has some other uses, but in particular atopic dermatitis, it's used for moderate to severe, very effective. Children, again, 12 years of age or older, and you need to have a weight of at least 40 kilograms, only prescribed by dermatologist or clinical immunologist, and the dosage is 15 milligrams a day for children. And again, you need to have a criteria of severe, moderate to severe eczema of at least 6 months duration and unresponsive to medium to high potency topical steroids or calcineurin inhibitors. Next slide. The baseline scoring to be eligible is the same as with Dupixent, an EASI score of 20, PGA of 4, and a baseline DLQI, and same eligibility criteria for severe facial or hand eczema. And ongoing treatment, again, has the same criteria. You have to get a 50% reduction in EASI score, DLQI reduction by 4, and for the hands and face, 75% reduction in surface area of involvement, or 3 out of 4 EASI subscores going down to nil or none, and DLQI reduction of 4. So if this is not achieved after 16 weeks, then you cannot get a further prescription for it. The downside with this one is that the side effects can be potentially more severe, and it does require a lot more monitoring. So you need to do all the baseline tests before starting, as you would do with the psoriasis biologics, and screen for Hep B, Hep C, HIV, TB, and making certain that the live vaccines have been given before commencement of the medication. So even though it is an easier medication to give because it's an oral medication, as opposed to Dupixent, which is a 2-weekly injection, it tends to have more side effects, and the side effects are particularly increased risk of infections like upper respiratory tract infections. Herpes zoster has been shown to occur. Some have nausea, abnormal blood parameters like increased LFTs, reduction in neutrophil lymphocyte count, which needs to be monitored, anemia, increased lipids, and there's also clotting risk. And in adults, non-melanoma skin cancer, increased risk. So this one we have not used as much as Dupixent yet in children, but there are issues here that we need to monitor carefully with this medication. So next slide. So following all this, I'm going to briefly mention facial eczema and the approach to treatment. Facial eczema is one of the most difficult problems with young infants, and often difficult to manage. And the main points to make with facial eczema is that we need to start using a medium potency topical steroids. So always start with Advantan fatty ointment, and if it's quite widespread, try even to do a bit of wet dressing treatment with Advantan fatty ointment, and consider escalating to something like mometasone or Elicon ointment for a short period to settle down the eczema. With more long-term requirement, of topical steroid, if you find you're using topical steroids a lot with facial eczema, then consider using a calcineurin inhibitor such as pimecrolimus or compounded tacrolimus, which you can get in 0.03 or 0.1% to prevent more long-term recurrent topical steroid use. Now, with the slide on the left shown here, you obviously have infected eczema, so always do swabs, looking for sensitivities, and they may need some oral antibiotics or topical antibiotics, and then you may need to gently remove and soak the crusts. And with the wet dressing treatment, you'd apply Advantan fatty ointment, then dermis afterwards, and then some Bactroban ointment in addition to maybe requiring oral antibiotics. And then with severe facial eczema, consider other diagnoses as well. Maybe the diagnosis is incorrect. So I'm going to show you a number of slides of potential differential diagnosis in severe facial eczema. So the first one is periorificial dermatitis or perioral dermatitis. It's usually in the perioral area. It can look a bit like eczema, but it doesn't quite fit because you have these multiple erythematous monomorphic papules, vesicles or pustules with sparing of the vermilion border, and there's no comedones, so that it's not acne, but these inflammatory papules have an increase in numbers, and there's central confluence and peripheral satellites, and it's of unknown cause quite often, or it may be a complication of using more potent topical steroids on the face or long-term topical steroids. And the only treatment really that's very effective with this is stopping topical steroids and greasy moisturizers and giving the child oral erythromycin for 6 to 8 weeks. Some of the topical treatments mentioned here are usually not effective unless it's very mild. So this is often difficult to recognize, especially if periorificial dermatitis is coexisting with atopic eczema. Then it can be difficult with facial eczema to recognize this, and sometimes we treat the eczema and the periorificial dermatitis with antibiotics at the same time. Tinea faciae, to consider if there's a unilateral presentation or you get some atypical sites with multiple erythematous scaly patches and plaques that are irregular with fine, coarse and irregular scales, satellite pustules, or if there's a history of exposure to pets like cats, dogs or guinea pigs, then consider tinea faciae, which needs to be treated with oral antifungals. Next slide is impetigo. So impetigo could be of acute onset, like here where you get an acute bullous impetigo, which needs to be treated with antibiotics, or there could be underlying eczema and you get secondary impetigo, and then you treat both with oral antibiotics and treat the eczema as well. And it's quite safe with secondary impetigo and underlying eczema to treat the eczema with topical steroids, and as long as you've got antibiotic cover for the impetigo. Next slide. This shows a slide with seborrheic dermatitis. Now, seborrheic dermatitis is usually earlier age of onset, so you may see it at birth or within the first few weeks of life, and then tends to get better between 3 to 6 months of age, whereas atopic eczema onset tends to be at around 3 to 6 months of age. So there's a bit of an overlap period when seborrheic dermatitis gets better and atopic eczema starts during that period between 3 to 6 months of age. It shows more erythematous salmon type patches with overlying greasy scale, and if you look elsewhere on the skin apart from the scalp, you will see areas of involvement around the eyebrows, glabella, also around in the umbilicus, and then in the intertriginous flexural areas, characteristically in the axillae and neck region, and in the nappy area where you don't see the classic, is not a classic site for atopic dermatitis, so that gives it away. And it's attributed to an overgrowth of Malassezia furfur yeast and often requires no treatment apart from just gentle cleansing, and resolves spontaneously. And you can use a combination of a mild azole like ketoconazole or econazole or clotrimazole with hydrocortisone, mild topical steroids such as hydrozole, or in more severe cases a triple cream of Advanta and econazole silicone, and it responds very quickly. So in summary, now when do you refer to a dermatologist? These are some of the main criteria to refer. A very severe early onset of infantile eczema is important to be treated aggressively, as from the presentation which Richard mentioned, that it's important to treat early severe eczema to prevent future food allergy and also to prevent the chronicity of eczema. So it's important there to refer early and often in combination with an immunologist. Difficult to control with adequate amounts of topical steroid ointment and wet dressing treatment. So if you use the adequate quantity as in the chart which I showed, and you've used adequate wet dressings but it's still not getting better, that would be another indicator to refer. Complicated eczema where there's frequent secondary infection, poor sleep, poor weight gain or failure to thrive, or atypical eczema in unusual sites. And an example would be an atypical presentation of erythrodermic eczema, where eczema is just generalized from early age of onset, where you may consider some other syndrome like Netherton syndrome, and it may not be all due to atopic eczema. Or it could be something like Langerhans cell histiocytosis, which can present in a similar way. Eczema affecting psychological function associated with anxiety, depression, or eczema that is likely to require systemic therapies which require close monitoring, or if you think one of the newer medications such as Depilamab or upadacitinib are indicated, which require referral to a dermatologist or immunologist. Thank you very much.
Thank you, Roland and Richard, for great presentations. Now, I'm just going to progress the slide here. Lovely. So to finish off, I'm just going to share some last few slides before we take lots of your questions, which we're really looking forward to. So this slide is really just to remind us that regardless of the age of the child or where the eczema might be, the principles of managing eczema are actually the same for all children. So we want these children to be happy, healthy children, playing outside, in nature, getting dirty, challenging their immune systems. That's all really important. And diet diversity is also really important for gut microbiome. We want these children to have a daily bath or shower where possible. And this is really important for a few reasons. These children are often recommended to, people will often say to have a bath, once a week or twice a week, but actually having a daily bath or shower is really important. It washes off it lets the kids be normal in the day and then have a normal quality of life, and then wash all the irritants and allergens off each day in the evening after dinner. Topical eczema treatments also work best when you apply them to damp skin. So really important to have the bath, hop out of the bath, then apply the eczema treatment straight away onto damp skin. And the third really important reason is that these children, they're more prone to skin infections, as Roland's mentioned. They've got more Staph aureus on their skin. So having a bath every day helps reduce that bacterial load. We recommend, particularly as these children often have dry skin, we recommend using a dispersible bath oil or a soap-free wash. They get out of the bath, pat the skin dry, and then apply their topical steroid to all eczema areas, not just the worst bits, and including areas of broken skin. They need to do that every day to all eczema affected areas until the eczema is cleared and the skin feels nice and smooth, and then they wean slowly every other day for a few days or every other day for a week, depending on severity. So they've had a bath, hop out of the bath, pat the skin dry, they've applied the topical steroid to all eczema areas, then they need to put moisturizer head to toe. And they need to continue that every day till the eczema's cleared. And then once the eczema's cleared, the skin feels nice and smooth, there's no longer itching, then they can stop the steroid. And then really important to continue with these daily general measures, the daily bath or shower, followed straight away by the moisturizer. As soon as the eczema flares again, we restart the steroid that night and continue again every day until it's clear. We avoid triggers where possible, and some of those triggers, are, I'll talk to you about them in a minute. Some are avoidable, some are not. We'll touch on that in a minute. Certainly the three most common reasons for children to be referred to when they present to our eczema clinic at Perth Children's Hospital are for these three reasons. So one, parents will either say, I just can't ever get rid of their eczema. There's always some eczema somewhere. So if that's the case, questions we need to ask ourselves are the parents or patients using enough? So we don't want to apply sparing amounts. We need to apply liberal amounts, apply it properly to all affected areas, not just the worst bits. Have we given them an appropriate steroid? Are they using something that's too weak? Are they using something like Dermate and need Advantin, something like that? So we need to make sure that they're using the right steroid. We need to consider, is there any underlying infection? And the other thing we need to think about, could it be something else? Are they not responding because it's not eczema? And certainly we get lots of referrals for things like a rash on a child's arms who is not responding to a moderate to potent topical steroid. So we need to think about, right, well, why is that? Oh, it could be something like keratosis pilaris. So always thinking about, if it's not responding, we've already mentioned that most eczema should clear very nicely in children, within 1 to 2 weeks for the acute eczema and 4 to 6 weeks for the children with more chronic eczema. So if the eczema's not clearing within a few weeks, despite using a reasonable potent steroid, we need to think about why. Then one of the other reasons are parents will often say to us, well, the eczema clears beautifully, but then it comes back within a few days of stopping the steroid. And so what's happening here is we're stopping the steroid too soon. So important because what happens is parents will use the steroid for a few days and then stop it once the eczema looks better, but they mustn't stop it until the skin is perfect. So we want to aim for perfection, then they can stop the steroid. But yeah, they often get quite excited because the eczema is looking much better. They stop it a few days too early, haven't completely put out settled the underlying inflammation. They stop the steroid and within a few days it all grumbles back. So treat every day to all affected areas until the skin's completely clear and feels smooth, then wean slowly. So what we often will say to these families is, rather than treat for a specified number of days, like 3 days or 5 days, treat the rash that's in front of you, because it might need 7 or 9 or 14 days. But the important thing is, we will often encourage parents to go back to their GP or to give us a call. If the eczema is not clear within 2 weeks, despite following their treatment plan, they need to touch base with us or with their GP. The other very common reason for presenting or for being referred to eczema clinic at the hospital is troublesome facial eczema, as Roland's already mentioned and summarised really nicely. Contact irritation from saliva, it's a really significant contact irritant around the mouth and causes lots of problems. So it's not uncommon for children to get frequent flares around the mouth. So using a barrier cream before and after meals and throughout the day when there's lots of saliva can be really helpful. So things like Vaseline, Dermis ointment, QV sting-free ointment, Aven Cyclofate, Kenkay zinc and castor oil cream are all suitable examples to use. Parents are often very worried about using topical steroids, and when they see that actually if they use them properly and use it properly to all affected areas every day and they've got the right steroid, next week we're not even talking about eczema. So they can see that, oh yes, if I treat it properly, then it will clear quickly and we won't have side effects from topical steroids because we won't be needing to use them long term. So it's really helpful for, we often will use the analogy of treating eczema like a bushfire. You need to bomb it, hit it hard, treat all the eczema areas until they're clear. And often parents will really understand the analogy of a bushfire, because parents will often describe, when you ask them, so where, they might have the right treatment and you say, so where are you putting your Elicon or your Novazone? And they say, oh, well, I'm just putting it to the worst bits behind the knees and the wrists, but what about all these other eczema areas? And we remind the families that the skin's one organ, they need to treat all the eczema areas rather than just the worst bits. treating it like a fire can be really helpful. A really common question we get asked about is, well, what moisturiser should I use? There is no one perfect moisturiser, and it really just depends on where the children are living and personal preference. So what suits one person might not suit everyone. The key thing here is, though, they need to find something that they can afford and that they like, because you need to use moisturiser every day long term till they leave home. The other thing is they need to use plenty. They need to put it onto face, tummy, back, arms, legs, hands and feet. Need to put it to the whole body every day after the bath. And we usually say once to twice a day to improve compliance with treatment. They don't need to put it on 5 to 6 times a day, just once to twice properly to the whole body, and that will really improve the skin barrier. We want to avoid lotions that, for most children with eczema, they're not moisturising enough. They contain too much water and not enough oils. And the other really important thing when choosing moisturisers is you want to avoid skin products containing food proteins. So things, nut oil, sweet almond oil, macadamia oil, those things, including goat milk. And often it's quite helpful to explain that eczema skin is like a brick wall. Roland's already mentioned this. So if the parents understand that the eczema skin's like a brick wall where the brick layers didn't do a very good job, there's lots of gaps and cracks between the skin cells and not enough glue, not enough mortar to hold those bricks and skin cells together, so moisture leaks out, and irritants and allergens from the environment, including food proteins, can pass into the body more easily and potentially cause cutaneous sensitization, development of allergy antibodies, which is why we don't want to use skin products containing food proteins, especially when the child's not yet started eating solids or eating that food. Common triggers, I'm not going to talk too much about this, but really helpful to remind families that anything that activates the immune system can flare eczema. So very common for, viral illnesses and vaccinations to flare eczema. So for parents not to panic if their eczema flares after a vaccine or a viral illness, just get on, follow the treatment plan, and next week their eczema should be clear. The other thing is that often we overheat and overdress our babies. So just talk to families or just remind families about not needing to wear, 3 layers of clothing during the day and the night and have heaters on all night. Just make sure they're kind of thinking about not overdressing and overheating their babies. As Richard mentioned earlier, there are lots of eczema resources. To save time and be able to answer lots of your questions, I won't go into each of these, but you're very welcome to, in your practice with clinicians, have a look at the various resources. There's the Nip Allergies and the Bub website, which Richard mentioned, and the 250K website, and at Perth Children's Hospital, under the Health Facts section, there's lots of eczema information there, as well as information for teens. We are available at Perth Children's Hospital to help if you ever want us to go through some more detailed eczema information for practice nurses or GPs. We do lots of webinars helping GP practices, so we're really happy to go through the nitty-gritty of how to do wet dressings, bleach baths. So all you need to do is contact us at Dermatology at Perth Children's Hospital, and we're very, very happy to do that. We're also very happy to answer any questions. We've got our dermatology registrar on call via switchboard Monday to Friday, 8:30 to 4:30, which is another great resource as well. So I hope that's been helpful. We're now going to answer lots of your questions and look forward to taking them. So ask as many questions as you like. Richard, Roland and myself are happy to answer all your questions. Thank you.
Okay, Jemma, so I'll call out a couple of questions that I've got here in the panel. So I've got, how long can a patient use a topical steroid safely if we are going in with a strong one like Elacon?
Yeah, so Roland might want to answer this as well, but I'll give it a start. So if you're using mometasone and it's appropriate for that particular, say, mometasone for the body, if you use it once daily, every day properly, within 2 weeks, the skin should be perfect for most children.
Yes, thanks, Jemma. Yeah, I agree. I think there's no sort of long-term risk with any potent topical steroids as long as it's used sort of intermittently, appropriately. So I generally have a rule of thumb that if you give a potent topical steroid a break for say in chronic eczema where you use it recurrently, if you give it a break for a similar amount of time as when you use it, it gives the skin time to recover from, you know, the normal skin around where it's used, from you know, the risk of atrophy. The risks are always that people worry about is atrophy, permanent atrophy, long-term atrophy of usage. And it of course depends on the site. So with Alicon, I wouldn't sort of use it in areas like the groin or neck area or the face for too long, unless you had to, and generally you don't need to. And probably more importantly, you're looking for complications of folliculitis, which can occur if you use it too long. But long-term atrophy, if you use it appropriately until the eczema clears and wean it off slowly, you can use it many times as long as you give it a break in between.
And I think the thing that parents often get confused about is they talk about long-term use, but when they talk about long-term use, actually what we're doing is treating the eczema flares until it clears, and then it's clear, and then you might need to use it somewhere else on the body 3 weeks later. So then they use it again. So helping them understand that that's actually not long-term consecutive use of the steroid in the same area of skin. Long-term can be helpful because sometimes they do misunderstand that differentiate or the difference between the long-term use and actually using it intermittently long-term appropriately.
And also I often ask them when, you know, some patients tell me, oh, I've been using this steroid now for 2 years or something continuously, and then I say, well, how many tubes have you gone through? And they'll say, oh, I'm still through half the tube of the Alicon ointment. So they've used half a tube in 2 years, so they've obviously not used very much at all, but they think they're using it long term. So it's better to just use it short bursts, like Jemma said, till it clears, and then you sort of wean it off. And if the new area flares up again, treat that area. But the aim is always to keep the skin clear of eczema and not to just continuously use it once the skin is clear. And so there's no sort of set number in terms of how long can you use it safely. Just if you follow that method, you can use it in a long term. There's no problem. But once you start I suppose you sort of need to get a little bit of an idea of how much the quantity of steroid it is that the patient is using it. I mean, if they start using authority scripts for 10 tubes of Alicon every month, and they're just doing that on a small surface area of the body, then you start to worry about it. And maybe they should be doing something.
You get a good, you know, once you've prescribed the treatment, reviewing them either by phone or back in person in a couple of weeks is really helpful, because you know that you should have had a really good response by then. And if you haven't, that's when you can either address, you know, you can kind of address how much are you using, where are you putting it, you know, those kinds of things, rather than just seeing the patient back in a few months' time when lots of mistakes are happening already early on.
Yep, I can move to the next question. So I've got another one of, is systemic TX safe to be used by GPs, or do you recommend patient to be referred to a specialist?
Sorry, which is the medication?
It was systemic, SYSTMIC-TX.
Systemic treatments.
Yeah, treatments, sorry. Yeah.
Sorry. I think probably best to refer to a specialist, because I mean, the systemic treatments we have available, they do require very well. First of all, you know, if we're talking about systemic treatments for eczema, it will be really azathioprine, methotrexate, or cyclosporin, which could be prescribed by the GP, but they would need very careful monitoring. I mean, they can be then monitored by a GP, but I think you probably need to be referred to a specialist first to start the treatment. And then Depilamab and Impetigo, which I mentioned, they do require specialists to do the treatment. But I generally, with Depilamab, ask for the GP to help with, you know, monitoring the patient for their injections. because they often are very helpful with the practice nurse to help.
I'll move on to the next one, which is what about the need for sun protection during steroid therapy?
This is for topical steroids in general, is it? Or
I believe so, yeah.
yeah, I think it is definitely a factor. Any sort of immunosuppression on the surface of the skin with anything like topical steroids, oral steroids, or even the systemic therapies, you always want to encourage maximal sun protection. Although, I mean, we do use also phototherapy for eczema, but the quantity of UV light that's used for phototherapy, along with using topical steroids, is quite minimal. But with our environment, I think it's an important thing in general.
Okay, that was actually the last question, so I'll just call if there is any more questions, if anybody wants to pop them down. Okay, so I believe there was a thank you for a helpful webinar. So on that note, I believe that we can end the webinar.
Thank you very much, everyone. Good night.
Thank you very much.
Bye.
Good night.
Bye.